These are the SLOs for the problem. I leave it for you to read. There are two types of wound healing. One is the primary, also called first intention. This is similar to the healing of the fracture, as surgical wound, which is a clean wound, no infection, very neat incision that can be sutured and closed, and it would heal. We all had cuts from amwas, banhilaqa, or okay, yeah, this is fine. مثل أمواس مع الحلاقة or سكين if you are doing some cooking. All right. Thank you very much. So we'll talk about this, and there is the secondary wound healing, which correspond also to the secondary fracture of the in cases of bone. The examples here, if you have an infected wound or an abscess cavity or an ulcer, there are a number of control mechanisms that takes place in between the various components of the skin, not only the epidermis, but also the subepidermal tissue, the blood vessels, etc. And they are divided into paracrine, autocrine, and endocrine factors. I will not go into the details, but I have tables that I will show you in a minute. Principally, if we have a fracture, if we have a wound to heal, that wound will be closed. It will contain a blood clot, like in the hematoma of the fracture, and with the blood clot there are platelets and there are thrombus formation which need to be removed. Again, like in the hematoma of the inflammatory phase of the fracture. The hemorrhage, as in the fracture as well as in the skin, need to be stopped and removed by the hemostatic mechanism of the clotting system of the body. Then there will be an interaction of several factors. I'll come to some of them in a minute, between the fracture, between the components of the coagulation and the growth factor coming up from the skin, leading to hemostasis. You need hemostasis. Why? You need hemostasis to phagocytose the debris. So the mechanism of formation is that once there is a wound and the wound is closed, that means there is no hemorrhage. There is no fresh hemorrhage, but there is a clot formation that need to be removed. From both sides of the wound, there will be a growth of capillary blood vessels to establish the circulation between both sides, both ends, as in the fracture. These capillaries will initiate a proper circulation, and it will facilitate the chemotaxis, that is the escape of the monocyte from the vascular system outside. Once the monocytes come outside, we call them macrophages. They will start to phagocytose all the dead material of the clot itself. It needs to be removed and replaced by fibrous tissue. The exudate of the chemotaxis that will return back to the vascular system, so there will be less leakage of cells. with the trauma or the surgical wound, which is an inflammatory traumatic inflammation, as you know, there will be a formation of fibrin. The fibrin is a mesh, shabaka, تشبك both the borders of the wound to facilitate healing. And along with the capillaries, what surrounds the capillaries are some cells called myofibroblasts. So they have two components. One is a fibro, which will lay out the collagen and the fibronectin, and the other is the myo, because once the function of the laying out the collagen is finished, then the myo element will start working by contracting the blood vessels, pressing on the blood vessels to close. If it closed, that means it would heal, so it would replace the whole wound by a fibrous tissue. There are a number of growth factors here involved, and I will take you to this in this diagram. It is from your books. If you enlarge it, there is a very good description here below that will take you step by step. This is a very beautiful diagram. There is a wound, this wound and the skin. Now this is the epidermis of the skin. This is the dermis underlying the skin, and it was made in such a way that you have this wound that need to be closed, and an opened blood vessel. The open blood vessels can be anywhere. Imagine there is a wound. There are hundreds of capillaries, small capillaries. Each of them will have the same reaction. With the thrombus formation there and the accumulation of the platelets and then the deregulation of the platelets, there are two factors released. One of them is the platelet-derived growth factor, and the other one is the transforming growth factor beta. The PDGF, which is the plasma-derived factor, will stimulate these cells in the epidermis, the epidermal cells. They start to divide. Okay, if they divide, that means they will not only divide, but they close up. They meet the opposite row from the other side, and they close the gap. If they close the gap, that means what is on top will fall down. What is in down, it will be cut up from the environment. No more infection, no more trauma. So it would facilitate the repair. These basal cells, they are also under another autocrine control factor that is coming from part of the skin, not the whole skin, only the epidermis, which is the epidermal growth factor. This epidermal growth factor is also influenced by the insulin-like growth factor, or many other nutritional substances. This one comes from the dermal myofibroblast, as well as it comes from the blood capillaries themselves. On the other hand, both of these factors, the platelet-derived growth factor as well as transforming growth factor beta, they have a chemotaxis effect which leads to the leakage, escape of the monocytes into the gap of the wound, and these monocyte or the macrophages, once they fill up the gap, they will start phagocytosing all the material, all the dead materials in the wound, be it part of the thrombus or anything else. On the other hand, these two factors will also stimulate the myofibroblast around the blood vessels to lay out more collagen, as well as they also lay out fibronectin. Fibronectin is also required, it will migrate into the wound to close it up. All right? So this is in simple terms how these factors affect the wound healing. And I listed to you here some table for you, those who are interested to find out exactly what is the function of each of these epidermal cells, these growth factors. There's another very beautiful tables as well here for your information, معلومات عامة if you wish. I listed them all separately here, each one separately. The reason for this is that if you are oriented towards exams, in the exams they ask you sometimes, give me one paracrine, or among a group, what is an autocrine? These are, or some of the mitogens, the ones which would enhance the cell divisions of the epidermal cells. The outcome of wound healing can be one of those, which is either organization of the fibrous tissue. I told you the wound will be replaced by fibrous tissue, by granulation tissue. The granulation tissue is made of inflammatory cells, made of exudate, made of fluid, and also made of fibroepithelial, myofibroblast. And if that granulation tissue mature and close, it will be replaced by fibrous tissue, which is a scar. So one of the outcomes is that there is a full organization of the granulation tissue and replacement by scar. It's scar if it is small, but if it is big and there is too much of fibrous tissue produced, that means too much of collagen, then it can be big enough. We call it keloid. It can lead to contracture. I have a picture, I will show it to you. And if the wound is internal, can get into the abdomen, for example, there will be adhesions between the lobes of the gut or anything else in between. I still have some time. Now, there are complications or abnormalities of tissue repair. I thought I'll bring you the common ones. There are three main categories, but many subcategories that you could get into these, but I lumped them into these three. Either there is inadequate formation of the granulation tissue. That means inadequate formation of a scar. So this is a very weak scar that can rupture at any time. Or there is an excessive formation of the components of the repair process, which is, in this case, so much of collagen formation, and this would lead to the keloid. Or there is an extensive fibrous tissue that mature enough, heal, but it would lead to contracture. As I mentioned, I have a picture. I will show it to you. In the first category, that is the inadequate formation of the granulation tissue, you consider these. There is either dehiscence. Hiscence, that means you have a full glue. It's ملصوق زين, but in dehiscence it will split, بفتش الhealing. This is splitting open or rupture of the wounds. You commonly see it in abdominal surgery or even in thoracic surgery, but because there is an increased intra-abdominal pressure, or because the patient is coughing, that it leads to rupture of the wound itself. Wound ulceration, if the ulcer is quite big and it reaches into the surface, there is no enough epithelium to cover it, it would lead to ulceration. You also see this in patients who have atherosclerotic changes, peripheral mainly, in cases of diabetes, and you see this in the lower limb. Non-healing wounds, if it occur in areas devoid of sensation, like patients who have neuropathic ulcers because of, again, of diabetic peripheral neuropathies. This is the group of the inadequate formation of granulation tissue. But if there is excessive formation of the products of the repair, mainly the collagen, then there will be hypertrophic scar. We used, in pathology, we use the same terms. Hypertrophic and keloid scar are the same. I think in clinically they are also the same. These keloids occur mainly in dark skin patients, and it occurs mainly also after thermal injuries of the areas involved, commonly burns also. Or there is an excessive formation of the granulation tissue with no coverage, no enough coverage of the epithelium because of inadequacy in the vasculature, which can also bleed very easily. Formation of a contracture, as I said, there is an exaggeration of the contracture of the parts involved that could lead to disfigurement of the parts. These are the pictures. In the first two, I mentioned the, I still have 5 minutes. The contracture, so this is the hypertrophic scar. I mentioned that they occur mostly in dark skin individuals for reasons that I don't know. As this is a lady. Imagine this lady هاي راحت عشان تسوي خرق حق اذنها for some cosmetic reason, تبغى تلبس حلق. After a couple of weeks started to develop this hypertrophic scar. This is a quite a benign condition. It is not even a tumor. They can be removed. So you have to alert them. The other part of the picture, there is the histology, just to convince you that this section is a keloid scar. The covering epidermis is unremarkable, and the whole dermis is full of collagen material. And in the lower picture, this is the scar. You see this commonly after a burn of the hand and arm. All right, and I showed you these factors, the factors that influence cell renewal and cell repair. I showed you this when we discussed the fracture. So I will not go into the details. This is the rest of it, and these are the constitutional features, factors that you need to consider in repair, from diabetes, anemia, etc. All of these will interfere with healing or fracture or any cell renewal, irrespective of the etiology. I took only a couple of factors that I would just expand a little bit. Diabetes is one of the factors that interfere with healing. It leads to defective chemotaxis. Slow the leakage of the monocyte outside the vascular system, leukocytes in general. It can also lead to less production of cytokines. That is the diabetes. Nutritional deficiencies, because you need vitamins and etc. And protein for the collagen of the matrix. Glucocorticoids are anti-inflammatory, so we tend not to give them in healing, because they interfere with the production of collagen. But we give them in corneal infection. Why? If it interferes with the production of collagen, they are anti-inflammatory. So they mix it. They mix the products, the drops or the ointment, whatever it is, with antibiotics. So it would kill the bacteria, but it would lessen the production of of fibrosis in the cornea, and therefore you will avoid corneal opacities. I think I'll stop here because I finished with it. Mechanical factors, you would read it, and poor circulation, you will also read it. I can respond to any question. You have 1 minute. For you just to read, and because I did not expand on each factor. It's quite a complicated issue, but this diagram of the interaction is quite enough. I wish to thank you for attending. Thank you very much. Inshallah, all the best.